Hello and welcome to Unstress Health. My name is Dr. Ron Ehrlich. Well, to any regular listener of this podcast, you will know that I enjoy inviting and speaking to practitioners, health practitioners with an integrative approach. And I also find it fascinating to explore what took them to that approach, because almost every medical practitioner is a product of their own education, and their own education is most definitely not an integrative approach. It's often a pharmaceutical approach, and that's when they feel like they are really being doctors. Well, anybody that goes to see an integrative practitioner knows that there is so much more to that, and it's a very empowering experience. Well, today we are exploring integrative psychiatry, mental health, the use of psychedelic therapy and nutritional therapy and ketamine therapy to deal with some intractable mental health issues. So my guest is Dr. William Vanderveer, and Will is a psychiatrist, an educator, and co-founder of the Integrative Psychiatry Institute. Now, with over 20 years of clinical experience, Will has led integrative psychiatry, psychedelic therapy, psychedelic-assisted therapy, psychotherapy, ketamine therapy, and nutritional mental health treatments. Now, these are all unique. Now, today we examine how trauma, stress, biology, and consciousness intersect, and what genuine healing in mental health really looks like. I hope you enjoy this conversation I had with Dr. Will Vanderveer. Welcome to the show, Will.
Thank you for having me.
Will, this subject that we're going to be dealing with today, of course, mental health, a huge and growing problem, arguably undiagnosed or overdiagnosed, depending on your perspective, and the use of psychedelics and nutrition and ketamine. We're going to be exploring all of these things. But mental health as diagnosed, I mean, we live in a world of evidence-based medicine. And what tests, how do we establish a diagnosis? Is there any clinical tests that one can do? Blood tests, blood pressure, hormone levels? What's the evidence for mental health diagnoses?
Gosh, that's one of the biggest problems is we don't have great testing. Yeah, you hit the nail on the head. You know, in the integrative work that we teach and live by in our institute, we teach practitioners how to identify and resolve a wider range of root causes than what I was taught in medical school or what, a typical doctor would think about for mental health. So, for example, when you ask the question, is there a test? Well, a person who looks depressed, let's just take depression, for example. That person could have a thyroid condition, and you certainly could diagnose that with a blood test. That person could have a very low vitamin D level, diagnosable by blood test. That person could have a very disordered gut microbiome that you could test and report back with. They could have Lyme disease that could show on a blood test. But the majority of what we see comes with a wide variety of different results on labs that are mostly inconclusive, typically. So it remains a field that's quite subjective.
I think it's worth, that was a little bit of a loaded question, I know, but it's one that I've interviewed many psychiatrists on my program over the years, and I think it's a sobering fact to reiterate that there is a subjective nature to many of these diagnoses, which is fine. And I love your approach of integrative psychiatry and a lot of the things we're going to be talking about today. You've said that unresolved trauma, I know, lies at the core of many psychiatric symptoms. And how does an integrative psychiatry fundamentally differ from the standard model when it comes to managing chronic stress and mental health issues? You've already mentioned a couple of things, but I wondered if you might just talk about that paradigm, the difference between an integrative and a more traditional, if you like, standard approach.
Right. Well, thank you for asking. This is near and dear to my heart, and I do my best to get the word out. So thanks for the opportunity to stand on my soapbox for a moment. the problem with how I was taught to practice psychiatry is that we use medication to suppress symptoms, and we don't go much further than that. There are some dinosaurs like myself who provide psychotherapy with medication, but by and large, psychiatrists are medication-only providers. So medications, when they work well, which unfortunately happens, for example, in depression, and only about 30% of the people who seek care, they suppress symptoms. They might make you able to function or cope, but they don't deal with all the problems that are contributing to your depression. Chronic stress you mentioned. So the chronic stress of being a human in the 21st century, the chronic stress of the barrage of information through social media, the chronic stress of climate change or political unrest, especially here in the US right now, the chronic stress of having a job that you don't love, or not having great relational tools in how to resolve conflict with your partner at home. The stress of raising children in an environment where social media is eroding their mental health, and facing the difficult decision as a parent, and I can relate to this, went through this with my child, of do I isolate my child and say you can't use all the social media and make you the weirdo at school? Or do I make the developmental psychology intelligent choice of limiting that for you? So we're living in a different world now. There's a lot of worry about jobs going away from AI, for example. There's a lot of reasons why we don't sleep as well as we used to. I could go on and on about the causes. Your question was about how do we deal with it? So first of all, we acknowledge that humans are complex. We acknowledge that having enough steps or enough activity, physical activity in your life is essential to maintaining well-being. We acknowledge that adequate nutrition is a critical part of mental health. We acknowledge that healthy relationships that are fulfilling are an incredibly important part of longevity and general well-being. So we might use medication in a sparing way, at a minimum dose or a minimum duration of treatment, while we really try to resolve these other targets for treatment. So that's the best way to describe this broader approach.
It is. I mean, it's absolutely music to our ears, and it's a theme that we've explored over the 10 years that I've been doing the podcast. So this is really music to my ears. It's sobering to know that in Australia, 1 in 6 Australians are on antidepressants.
Wow.
Yep. That the 95% of prescriptions written for antidepressants in Australia are written by GPs.
Okay.
And the average GP appointment goes between 8 and 15 minutes.
Wow.
That's
so sad.
Those 3 statistics are quite incredible, given what you have just defined as the difference between an integrative approach and what people may know as the standard approach.
Right.
But of course, you mentioned so many things there about conflict resolution, resolving conflict, something that is sort of almost built into business models nowadays. The challenge digitally of the digital world, again, engagement and the business model. And of course, the importance of relationships. And I think Harvard have done the biggest study ever on relationships approach, psychedelic approach. And it's a subject that we have explored a few times on our podcast, but the Integrative Psychiatry Institute, the IPI's year-long psychedelic-assisted training therapy is attracting a lot of attention internationally. What makes this approach so effective for things like treatment-resistant anxiety, depression, trauma, and what surprises many clinicians when they learn about it properly? What makes the approach different, and what surprises practitioners when they engage with it?
Right. Well, it's very new, very different inside of the mental health world to be talking about psychedelics. And it's very exciting that Australia has put the staff in the ground and said, okay, we're going to give this a roll and see how it goes. Quite bold from our perspective over here.
That is not the case in the States. You're talking to me from Boulder, Colorado in the US. What is the legal position of psychedelic-assisted therapy in America?
Well, I'll try to keep this concise because unfortunately, it's a complex reality. So we have ketamine therapy, which we could talk about later if you want to.
We will.
That is on what we call DEA Schedule 3. So it's readily available. It's fully legal federally. So you can go into ketamine therapy anywhere in the United States or in the world, almost anywhere in the world. There are countries in Europe that haven't embraced it yet, but it's a legal psychedelic drug. We have psilocybin that's been approved here in Colorado and also in Oregon. And we have run trainings in both states, training therapists how to work with psilocybin. And then we have MDMA, which unfortunately was not approved by FDA in the summer of 2024. So there are a couple of pharmaceutical companies that have developed patented psilocybin molecules that are reaching the end of the final phases of FDA research and may be approved later this year or early next year. I'm personally hoping that we get a federal approval as soon as possible because each state has its own rules and its own training requirements, its own sets of very high fees for licensing therapists, expensive regulatory systems that cause the medicine to be expensive. People need to travel if they want to have psilocybin therapy to Oregon or Colorado, which is expensive. And many centers, unfortunately, in Oregon are closing because it's too expensive in Oregon to provide the treatment. So the state by state experiment is not going well so far. And we have other states that are trying to adopt these laws. But personally, having been in the trenches with the state models, I would really prefer to see us take action on a federal level as soon as possible. So when I said that Australia had embraced something different from the US, my understanding was that you had a federal authority for certain doctors to prescribe MDMA therapy, which we don't have yet here.
Right. But the IPI, tell us a little bit about that institute.
Yes.
And the approach, how it is approached.
Thanks, Ron. Well, we've trained a number of Australian therapists in our program, which has been fun. And some of them are working in clinics providing MDMA therapy in Australia, which is really exciting. The program we run covers the three medicines, MDMA, psilocybin, and ketamine, on the idea that some people will find jobs in clinical trials, or they live in states where hopefully we'll see a federal approval at some point, or they can begin working with ketamine therapy right away. So we locate psychedelic therapy inside of this integrative framework, which is different from how most people are approaching psychedelic therapy. And we could talk about that too. So the conventional or the traditional approach, the pharmaceutical approach in psychiatry, is also being applied to psychedelics, where most of the ketamine provided in this country for mental health problems is provided without therapy. So you sit in a dark room, there might be other patients in the room with you, there's no therapist, there might be a roaming nurse to check on you, but you're having a psychedelic experience. And if you're not familiar with having experiences like that, you could have trauma come out during the session and nobody's there to help you. So unfortunately, that's how a lot of the ketamine work is being done here in the US. But there are clinics that are embracing and taking a big stand for the psychotherapy component of it, which is critical because, again, if we're looking at resolving root causes, then we want to discover and handle the trauma that may come out effectively and not just re-traumatize the person by not having enough support in the room.
Well, I mean, you were also mentioning exercise and vitamin D and thyroid function and sleep. I mean, I think this is probably what distinguishes a more integrative approach from the standard model anyway, I imagine.
Yes. Yeah. So the trouble with psychedelic therapy that is not framed inside the integrative model is that, we have these clinical trials now that follow people for 6 weeks or 8 weeks or 12 weeks. And oftentimes the participants do well for a few weeks. And if you work with ketamine as a mental health treatment, you know pretty quickly that the effects, the benefits tend to wear off within a few weeks, which is a huge problem because the last thing I want to do as a psychiatrist is tell somebody they need to come back and get ketamine again because it's stopped working.
Hmm.
I mean, maybe the person was on Prozac before and now they're on ketamine. Prozac arguably is less toxic and dangerous than ketamine in the long run.
Hmm.
So now you've got a person who's on a controlled substance that could be addictive, and now they're having to come back and get it over and over again. So what people are not understanding inside of this maybe hype or hysteria around psychedelics is that you can't bypass the things that keep you well. You can't not deal with your relationships. You can't not deal with your diet. You can't not deal with your sleep and your media addiction and so on. And doing all that hard work of behavior change is very, very difficult, and it takes time and an effort. So the bonus or the benefit of the psychedelic in that framework is as a catalyst to help someone connect with deep empathy for themselves or a deep sense of belonging or connection to the universe, and recognizing your own inner divinity, for example, and these mystical experiences can be incredibly transformative, but they're a moment in time. And then you have to do the work to make a new baseline, to make a new reality.
I mean, we could be talking about any health condition, and our modern healthcare system, by and large, in the majority of cases, I think we could argue about whether it's 80 or 90% or more or less, but around there, is very much on symptom-based pharmaceutical management issue, and the integrative approach always stands out as looking at root cause. I know that we've done a program on trauma, and it was once described to me as an event which just kind of circulates, goes round and round in a part of your brain that just gets stuck. It's the trauma being relived, being re-experienced over and over in your head. And one of the exciting things about the psilocybin or the psychedelic approach, be it MDMA or psilocybin or ketamine, is the opening up of pathways within the brain, literally the opening up of pathways, allowing you to process it.
Absolutely.
I mean, that is, as you use the word catalyst, to unlock that potential must be quite exciting for
it is
patient
incredibly exciting. It is. I mean, as a practitioner, it's like watching the highlight reel of your, rather than sitting through a 3.5 or 4 hour game of your favorite team, you're watching the 4 hours happen in super, fast forward. So you're seeing the changes happen. For example, in some of the clinical trials I was involved in, we had people who had been suffering for 29 years on average with PTSD before they came into the MDMA study. Some people had hundreds of therapy sessions. There was one person who had over 1,000 therapy sessions prior to coming into the study. And to see those people get well and resolve PTSD, where they don't meet the diagnosis anymore after 3 sessions, was just mind-blowing as a practitioner. And of course, it makes you wonder, why are we telling people that they need to try and fail, X, Y, and Z therapies before they can have access to this treatment? Why should they suffer for 3 years or 5 years or 15 or 30 years before having an effective treatment?
You used a word there which I think we need to highlight and repeat again, because it's not a word that's often used in mental health issues. You said resolve.
Yes.
Resolve. Now that's just not a word that many mental health practitioners use. And I think we need to just come back to that a little bit, because, I mean, managing a chronic mental health issue is a great business model. It's just not a very good health model. But here we have something, you use the word resolve. Please explain that a little bit more.
Well, in the MDMA work, we have long-term follow-up. And the remarkable thing is that most of the people who achieved remission stay in remission through the long-term follow-up. And we're talking about 3 exposures to MDMA in the case of this body of work that I'm talking about. With psilocybin, which has mostly been studied for chronic depression, 1 or 2 psilocybin sessions is showing across multiple studies 6 months to 12 months of relief from depression. So the prospect of someone needing to take psilocybin once a year, a few times in their life total, versus treatment as usual that you and I have been talking about, it feels less toxic. B, it feels a lot more affirming and hopeful for someone's condition. So these connections in the brain, it's very interesting when you sit in the room with someone who's having a psychedelic therapy experience. Some version of the metaphor, I'm seeing my life, I'm above the forest, I can see the forest for the trees. I see what happened. I see that I was there. I see that I participated. I had my part to play, but it's not my fault. I'm not to blame for the car accident or the death or the terrible thing that happened. And it's time for me to move on and live my life. You don't have moments like that in ordinary therapy very often as a practitioner.
I mean, I think, and I've had this experience myself in therapy with a psychologist, so I have to speak from some experience, but the difference, of course, you use the word catalyst to open up those pathways. I can only imagine that an integrative approach would be a great way of solidifying the foundations on which that catalytic experience has occurred. And I think there are very few mental health or healthcare therapies where people would describe them as one of the 5 top experiences of their lives. I mean, let's just reflect on that for a moment too.
It's
You've
remarkable.
heard that, obviously.
Yes, the work of Roland Griffiths out of Johns Hopkins, and mystical experiences and so on, ranking an experience from therapy on the same level as the birth of a child or a marriage day. Quite remarkable. And these experiences stick with people, and they carry them. Especially in the case of psilocybin, it doesn't appear that, first of all, it's important to say that outside of ketamine's a different animal, but outside of ketamine, these drugs do not appear to be drugs that people become addicted to. They, in general, don't go looking for opportunities to use the drugs after the treatment, because the whole experience of this catalytic moment is so sacred and meaningful that it wouldn't make any sense to approximate it in ordinary life.
Yeah. Yes, I would concur with that, because it was quite an interesting, that's an understatement, a very interesting experience for me, and one that I've reflected on, and this was probably 2 years ago, that I've reflected on many times since then, but I had no desire to go back and, I must try this again next weekend, that was terrific. No, it wasn't like that at all. I'm interested though, Will, because you have been in healthcare for some years and you went through traditional training. I'm always interested to hear the personal story, the epiphany, or what prompted the change in your approach as a psychiatrist, as a medical practitioner.
Well, thanks for asking. There have been a number of inflection points. The first one happened, I graduated from my psychiatry training and I had the tools that they teach and, that you get board certified to provide. And those things included, of course, medications and some forms of therapy. So I was doing cognitive therapy and a little bit of psychodynamic work, looking at people's histories from their childhood. And I was helping, but there were a lot of people who didn't respond to the medications, which is what we now know is the norm, is, more than half of people who take medications in my world don't get what they signed up for. They get side effects or they get ineffectiveness. So I was growing more and more desperate. And just a couple of years after I graduated from my training, this is more than 20 years ago now, I quit psychiatry thinking, okay, well, I'm going to go do something different. And one of my patients who I had treated prior to quitting, this is the first time I quit psychiatry. There were other ones later, but this time I ran into one of my former patients and while I was on this break from psychiatry, and he pulled me aside. This was a lovely gentleman in his mid-30s. He had terrible anxiety, social anxiety, agoraphobia, which is a fear of going outside of his house. He couldn't travel. He couldn't date. He had an interesting symptom that didn't make sense to me at the time, but he said that whenever he ate a sandwich at an airport, he got very panicked. And I didn't think anything about it because I didn't know any better. So I quit psychiatry. I ran into this guy on the street and he said, look, I want to thank you for being a kind doctor who clearly cared about me. But I want you to know that after you left your practice, I went and was tested for celiac disease. It came back positive. And I stopped eating wheat. And over the course of about 6 weeks, my anxiety melted away and it was completely gone. And the SSRI medication and the benzodiazepine that you had prescribed me, I gradually tapered those off for the next 6 weeks, and I still have no anxiety. And he still lives in Boulder, and I keep up with him. He's still without any anxiety. He went on to date the woman that he would sit in my office and say, I can't ask her out even though I want to. They have 2 kids. One of them was tested positive for celiac right away. So that child will not have the journey that he had with problems from eating wheat. So that was a huge wake-up call for me. And I realized that I didn't have the knowledge I needed to be effective. And so that led me into this whole integrative question and going and doing a lot more trainings and learning about infections and gut microbiome and chronic stress and adrenal fatigue and learning how to prescribe hormones and vitamins and assessing for nutritional deficiencies and trying on different frameworks for understanding even more severe conditions like bipolar disorder and schizophrenia, and really interesting work that's been done in those fields that's not well known, but good science, and started trying different things. And I'm very grateful to my patients for going along on that ride and, as best we can using the evidence and following the evidence. But when you go outside the mainstream, there's less evidence to support what you're doing. So you have to be mindful of that and, tell people that that's what's happening when you're recommending high dose niacin for schizophrenia, for example.
Yes.
So that was a big wake up call. And then the psychedelic piece came later for me. I was a very straight kid. I had never tried a psychedelic in high school or college or any time prior to getting a call from a friend of mine who asked me if I would consider getting involved in this MDMA-assisted therapy trial. That was about 15 years ago. And my response to him was, well, isn't that the stuff that causes holes in your brain and the kids party with and get in health problems with at raves and so on? And he said, well, why don't you look at this study that was just published about a small group of people with PTSD? And I saw that the paper was reporting 80% resolution of PTSD after 3 sessions. And I thought, wow, I'm lucky if I can get 20% resolution of PTSD. As you said, these are rare terms to use in the field of mental health. So that got my attention. I got involved and I saw what was happening in the room, and I got to refer some of my own patients into the trial we were doing and see them heal. So by the time I was done with that trial, it was clear to me that I needed to be an instrument in helping this work become more mainstream.
Well, you've mentioned nutrition there, and nutrition has been a focus of my professional life for over 40 years, and functional medicine is a huge and growing area. We actually interviewed the father of functional medicine a few weeks ago, Jeffrey Bland.
I saw that on your podcast. Yes.
Yeah, and he's been a mentor of mine. I did his first course in 1981.
Wow.
And it came as cassettes. It was mailed out as a cassette thing, audio cassettes. But, and you mentioned niacin and B3. Right. There are different forms of vitamin B, nicotinamide, and the more active form, niacin. We've done programs on that, and I'm actually on the board of the Orthomolecular Medicine News Service.
Wow, amazing.
Yeah. Okay. So you're talking my language here.
Okay,
but nutrition and mental health are not often connected. I mean, nutrition and health, sadly,
right.
Lip service is paid to them, but your nutritional psychiatry program, and you've just mentioned gut health. I've got a gut feeling that there's a real thing there. Inflammation and, interestingly, mitochondrial function. And now that is the buzzword in every health. You go to a course on autoimmune, metabolic health, mitochondrial health is there. You go to a course on cancer, metabolic health, mitochondrial health is there. You go to a course on anything, not surprisingly. It's how it manifests itself that is perhaps has a genetic component here. But there are many commonalities here, aren't there? How often do you see mental health symptoms resolve or, well, you've already said resolve or significantly improve when those foundations are addressed? What kind of response do you get to just foundationally sorting out a person's nutrition first?
Hi, Dr. Ron here, and I want to invite you to join our Unstress Health community. Now, like this podcast, it's independent of industry and focuses on taking a holistic approach to human health and to the health of the planet. The two are inseparable. There are so many resources available with membership, including regular live Q&As on specific topics with special guests, including many with our amazing Unstress Health Advisory Panel. Now, we've done hundreds of podcasts, all worth listening to, with some amazing experts on a wide range of topics. Many are world leaders. But with membership, we have our Unstress Lab podcast series, where we take the best of several guests and carefully curate specific topics for episodes which are jam-packed full of valuable insights. So join the Unstress Health community. If you're watching this on our YouTube channel, click on the link below or just visit unstresshealth.com to see what's on offer and join now. I look forward to connecting with you.
Well, there are a couple of caveats. The first one being how disordered is the nutrition at the beginning. So, the delta that you're going to see between the starting point and the end point has something to do with where the person's starting.
Yeah.
Right. So, for example, if you came to my office, I assume you probably have excellent nutrition given your education. Maybe that's not a fair assumption, but I think it probably is.
So I try to do my best. I work on an 80-20 rule. And if 80% of what I do is good, then I can live with that. When I'm really on fire, I'm a 90-10 person. And at various points in my life, I've been 100%er, and I've been such a pain in the ass. No one wants to even socialize with me. So there's a balance there, isn't there?
Of course.
80% is a baseline that I think is acceptable.
That's fantastic. So that's one piece, is how much change can we expect based on what the person's starting point is. And I've certainly seen people go from a mostly fast food, high pro-inflammatory sort of anti-mitochondria diet to a dramatic shift in mental illness conditions by improving the macros and the micros and really going after inflammation as much as we can and following it along. That's, one of the nice things about inflammation is it's not hard to follow with blood work. The other piece, the other caveat you already mentioned, which is a beautiful way to talk about it, is the relational and social component of a person's mental health. So if their social world is very isolated, very bleak, or high conflict, then the nutrition, in my experience, even if it's robust, even if they're at that 100% mark you were talking about, is probably not going to overcome the cortisol bursts and all the, chronic despair and existential challenges. Again, people are complex. So one person's going to have a boost from only the nutrition. Another person is not going to see as much benefit from that. And I think a lot of it is what you said of the pathways and the genetics involved in that.
I love that, actually, though, Will, that you've drawn that really important point about where is a person starting from, because that transformation from fast food, almost exclusively processed diet, to just a nutrient-dense diet, we're not even talking about food sensitivities or gluten sensitivities or whatever, is huge. You also mention relationships, and those certainly have been something that I've focused on too. In more recent times with mitochondrial function, circadian harmony is another. This is a whole new area as we focus on mitochondrial metabolic health. the importance of circadian. I mean, as I say, I've been in practice for 45 years, but it's really only been in the last 5 or 10 that I have truly focused my own health and my patient's health on circadian harmony.
It's so fun to be in the field right now because we're learning so much more than we were for there were a couple of decades there where it felt like it was pretty much crossing the desert and there weren't as many new phenomena coming. Now we have the functional medicine continues to grow, and like you said, inside of the mitochondrial conversation, there's a lot of hope of getting somewhere with people who were very stuck for a long time.
It's also interesting to hear you use the words, it's exciting to learn, because I think there are many medical practitioners, I don't want to be too negative or disparaging here, but many medical practitioners who feel that if they haven't read it, then it's not worth reading, it's not worth knowing. And if they don't know it, then it's all in your head or it's genetic. So
right.
I think it's interesting. I like yourself. The more I learn, the more I realize there is to learn, and I find that exciting. But for some people, not so. You've mentioned ketamine a few times, and that is an area that I must admit I know very little about. It's become a significant part of mainstream mental health. When is ketamine most effective? How do you make that decision about, we're going to go psilocybin, we're going to go ketamine, we're going to go MDMA? What prompts you to use ketamine? How is it used?
Well, ketamine for a long time, prior to even state approvals of psilocybin, was the only game in town. So, we used it for many different targets, acute depression, chronic depression. The long-term treatment-resistant depression tends to be a highly inflammatory condition, typically. Ketamine is a very strong anti-inflammatory.
Interesting.
So it has that acute effect on inflammatory pathways in the brain. The advent of psilocybin creates a kind of a decision tree where you could say, well, this person has chronic depression. What are you going to use to treat this? And as I said before about ketamine benefits not lasting for very long, I think if you present most people with the facts of the likelihood, if we're in let's just say we're in a pharmaceutical traditional model and we're not in the integrative model just for a moment, even though it's painful to go into that even for a moment.
I'm with you on that, but let's do it anyway, Will.
Okay,
let's do it anyway.
All the other variables are the same, and we just trade out psilocybin and ketamine. Ketamine has a unique, very powerful anti-suicidal thinking effect that seems to be unique about ketamine. So much so that emergency rooms that tend to treat people who are with acute suicidal thinking are giving people ketamine in the emergency room and seeing it diminish or resolve pretty quickly, within a few hours sometimes, which helps keep people out of the hospital, which keeps, the insurance companies happy. And hopefully it keeps the patients happy, more importantly. So in a world where everything is available, which we're not quite there yet, but if we have MDMA, psilocybin, and ketamine all available, my drug of choice in treating PTSD would be MDMA. If the person's medically appropriate for MDMA treatment, and there are people who are not, there are also obviously rule-outs for ketamine and for psilocybin as well. But I think that the evidence base and my own experience in clinical trials, watching people with chronic PTSD kind of wake up and walk away from their PTSD is just quite remarkable with MDMA. So you can treat PTSD and trauma with psilocybin and ketamine. And, there are studies, not very big ones, but there are studies with those drugs to treat that condition. But it seems like the long-term minimal intervention play is going to be psilocybin for depression and MDMA for PTSD. But I think ketamine will continue to have this almost urgent or acute rescue role. But I think, as I said, once people have enough the practitioners have enough experience under their belt to know the differences and the pros and cons and the drawbacks and benefits. It's going to be a little hard to offer a patient something that might wear off in a few weeks, and then they need to come back and keep coming back and keep coming back. And then, of course, there's the risk of ulcerative cystitis, which is an irritation of the bladder that comes from chronic ketamine administration. It's not common, but it does happen. Even people just getting ketamine for medical use. So it's going to be interesting. Obviously, there are also other compounds that are being developed right now that we're not even talking about. It's probably beyond the scope of this conversation, but there's a lot happening in the field.
Well, I can only imagine that drug companies would be falling over themselves to come up with a patented, because psilocybin's been around for quite some time.
Definitely.
Arguably
longer than we have.
Thousands, if not millions of years. And that's a problem for the healthcare industry, because if you can't make a huge profit out of it, it may not find its way in. But you've mentioned therapy as being an important part, because so much of this, as you've used the word catalyst before, opens up a pathway. I know in my own experience, a session before with the psychologist was a discussion about what my intention was. What did I hope to achieve? What did I hope to explore? And I can just imagine that this being a catalyst for more complex issues would open up a pathway for therapy that you could have only dreamt of when you graduated. What sort of therapies are you using? Because I know this is a big philosophical question, isn't it? Because there are so many different ways of approaching it. How do you incorporate talking therapy, I'm assuming that's what you were talking about here, talking therapy, psychotherapy, into the use of these compounds?
Well, I think one of the most powerful ways to incorporate psychotherapy with these compounds is to develop a strong therapeutic alliance, a good relationship prior to the dosing session. And sometimes that process is difficult because trauma that has roots in relationships. So interpersonal trauma can make it very difficult for a person suffering that condition to trust caregivers or therapists. And this is another reason why MDMA therapy, I think, is an incredibly powerful option for PTSD, is because of its unique boost of the hormone oxytocin that allows someone to not only feel self-compassion, but also to trust the caregivers more effectively, more quickly. So much so that it's a common phenomenon on the morning after an MDMA therapy session to have what some people call a therapeutic hangover, where you start doubting, you start wondering, how did I trust these people that I don't even know so much that I told them things I've never told anyone in my life? Yeah. And it's scary to be facing that the next day. And it needs to be acknowledged and understood for the trainees who are going to be providing this therapy, that that's a risky window for the patient. You were asking me about therapy and how to use it. Talk therapy is quite difficult it doesn't even really make sense when people are having trouble following language. For example, if you were going to conduct cognitive behavioral therapy while someone's on psychedelic.
I mean, when you're on psychedelics, ketamine, MDMA, there's no time to be talking to anyone. They're very much in their own head. But I mean, around that session, because I don't think, we're assuming that everybody knows how this is administered and how this is used. So let's come back to 101. Great. How a patient walks into your practice as a new patient and are looking towards this. I mean, run us through briefly how that would be.
Well, ideally, we would offer a handful of preparatory sessions, at not just one, but a few. And this is how the research was conducted with MDMA therapy: is 3 preparatory sessions once a week, 90 minutes each, and then a dosing session. The dosing session is anywhere with ketamine, 2 hours, 3 hours, up to, with MDMA, could be 6 or 8 hours. Psilocybin, about the same length of time. There are studies on LSD. LSD is a very long experience, 12 hours. So these are long sessions for therapists to sit in, and that's a whole nother conversation about the practicality of that. So after the dosing session, we like to provide a handful of integration sessions to discuss the insights, the take-home messages, the pieces that are going to be anchors for the person to come back to in the future to remind them of the possibility that was experienced during the dosing session. Because dosing sessions really are glimpses of possibility. They don't establish in and of themselves a new reality, a new baseline. There's a religious scholar from UCLA named Houston Smith who said, the purpose of spiritual practice is to go from state change to trait change. And I think it's a beautiful way to think about psychedelic therapy is you're having a state change with these connections and pathways in the brain that you mentioned before. But those connections are very temporary. There's a window that opens up where new things can happen. But the window doesn't stay open. And so the behavior change needs to start to take place. So from an integrative perspective, we would use the preparatory sessions. Sure, we would talk about intention, absolutely. And we would answer questions about the fears that a person has about what they're about to experience, informed consent, all the things. But we would also try to identify what the targets are going to be for behavior change after the dosing session. So we're already doing integration before the dosing session in a way. So, when you work with people the way I have for many years who have severe depression, having that person in your office for the first time and saying, you know what, you don't exercise, you need to put on your running shoes and that's going to make a big difference for you. It's not the way you approach that,
Yes, I'm sure experience has taught you that. That's probably how you did approach it when you learnt about how important it was.
Exactly.
It's the delivery. I always liken sometimes healthcare delivery to a stand-up comedian's routine. You see what works with the patient and then you reflect and go, yeah, look, I know I felt better, but I'm not sure the patient did.
Right. There was a famous physician, I'm trying to remember who it was. It might have been William Carlos Williams, who said that our job is to entertain the patient while the patient heals themselves.
I've read that. I thought it might have been Voltaire as well. There's been a few people that have said that, but there's a lot of truth to that.
I think so.
This is why anybody listening to this, be they a practitioner or a patient, if we were talking about the standard model of healthcare, which often involves the prescription of a medication, and a practitioner or patient is listening to this thinking, well, this is a different medication, isn't this great? And it's going to be really effective. Well, that's really not using it the way it could be or should be. And this is why the integrative approach, your preparatory sessions, then your sessions afterwards to literally bed in foundational things to make the foundation on which a person proceeds strong, are so important.
Well, there's a lot that is important about education. When I was trained as a psychedelic therapist 15 years ago, I didn't understand that. I didn't understand what a know-it-all I was as a practitioner. I didn't realize how much gratification and ego support I was getting from saying the smart thing that someone said, oh yeah, that's a really interesting way to think about that. It's very unhelpful to interpret someone's experience when they're on a psychedelic medicine. The purpose is for them to connect with their own inner wisdom, their own inner knowing, and for the client to have that space protected for them so that they can do that work. And that's a very different model for clients and practitioners.
Go ahead. Sorry. Well, I was going to say part of the problem, I think, is that the way we learn as practitioners is very didactic.
Yes.
We go to a lecture, we sit and listen to the expert, we take notes, and then we convey that knowledge. But that's not facilitating a patient's healthcare journey by lecturing them, is it?
No, it's not. It's really not. And so it's quite revolutionary, actually. The paradigm that the doctor or the therapist or, the person who's got the authority and the power in the situation is not the holder of the healing process, actually. They are the protectors of the space so that the healing can occur. And, that can sound a little woo-woo, or it can also sound a little frightening for patients who are used to being told that, here, put this in your mouth and you're going to feel better. Or I'm going to tell you how to live your life and you're going to do, if you follow my instructions, then you're going to do great. If you don't, you won't. So it's a very empowering approach to make it between the client and himself rather than to be the,
Well, I've often said, and I don't think many of our listeners in this program would be that person, but if the only thing you know about healthcare is your doctor's phone number, you are in serious, serious problem. But that brings us to another point about the healer's own journey, right? Because we've been very focused on we've had some great stories about doctors going through their own epiphany. And in Australia, there was a study done a few years back which identified that 60 or 70% of medical practitioners and nurses, and medical students for that matter, are suffering from burnout, characterized by the acronym DIE. D, disengaged, I, feeling ineffective, and E, being exhausted. So the healer's own journey is really important here. I mean, I know you believe clinicians should undertake their own healing work, and given those statistics, that's pretty important. How does a practitioner's personal inner work affect patient outcomes, and especially trauma-informed and psychedelic-assisted care? I mean, I know you didn't as a student experience this, but you must have personally since then.
I have since, yes. It's critical. The best way to describe the inner landscape to people who haven't had a psychedelic experience, in my latest draft of trying to explain that to people, is that it's a little bit like the movie The Princess Bride, or one of these movies that's a fairy tale environment where you have fire swamps and you have beautiful castles and you have meadows and you have scary places. And when you take a psychedelic, you don't know where you're going to go. You could go to a very beautiful place. It could be very scary. And if your job in the psychedelic session is in the seat of the guide or the therapist, and you yourself as the guide have not explored those dark and scary places inside of your own mind, then you're much more likely to act impulsively on your own anxiety and intervene and pollute the environment that the client is trying to heal inside of. So this is one of the reasons why people who are very experienced with their own personal journeys in healing, it doesn't have to be with psychedelic medicines. People who have had near-death experiences or mystical experiences that were not caused by a psychedelic medicine, all kinds of life experiences, the death of a child, things that are very difficult. They prepare you to hold space for people who need to move through these difficult parts of the landscape. So it's a common phenomenon for people who are in the beginning of the work, I'm talking about the practitioner here, to not appreciate how dark and scary and difficult it can be to be in some of these places in one's own mind. And so the view, again, I love this view because it's very different from what I was taught in psychiatry, is that what we're going after is wholeness. We're going after not trying to get on the sunny side of the street and stay away from the shadow, but we're trying to embrace the wholeness of what we are as human beings. And when we do that, we can feel incredibly empowered to face whatever adversity and challenges we're going to face in our lives going forward. Because life is full of that. It's full of big challenges.
And given those statistics that I just shared with you about the mental, and I don't even know about physical, but the mental health of health practitioners delivering our healthcare system, boy, that is even more critical than ever.
Very disturbing. It's a very stressful career choice on the level with first responders like paramedics and firefighters and anyone who's on the front row of human suffering.
Yep.
And this concept of, or not concept, but experience of not having the tools or the resources to be effective in the healing process is very common. I remember reading somewhere that the best recipe for burnout is to have maximum responsibility with minimum ability to affect one's environment. And I think that's how a lot of physicians feel.
Just unpack that a little bit more for me, because that's
Right.
quite a big statement that, yes, try and expand on that a bit.
If you work in a healthcare system, the rules are quite clear what you're allowed to do. It might not even be allowed to hold someone's hand, in certain circumstances, a patient who's going through a procedure or something like that. There's a formulary of drugs that you're allowed to prescribe, and you're not allowed to spend more than 10 or 15 minutes with a patient. Maybe you have a quota and you're supposed to see 40 patients a day, like is common in primary care. These are formulas for burnout because the level of responsibility doesn't go away. It increases the more people you see, the more patients you see. So, and then of course, we also have the other issue with paperwork. People imagine trying to see 40 patients a day and having a note on every patient. And when do you do that? And a lot of practitioners are going into their electronic medical record at night after dinner, hopefully with their family, and then, working to write their notes for a couple of hours after that. And it goes on and on. I mean, the debt, I don't know how it works in Australia, but here it's very common for people to have hundreds of thousands of dollars of debt coming out of medical training. And if you go into primary care, then, you're expecting a salary of $150,000 or $200,000 a year, and then you've got student loans for 30 years. I mean, it's really bleak. It's terribly bleak.
Yeah, you've described the medical system here in Australia as well, and for that reason, it's not that surprising. 8 to 15 minutes, you'll be investigated if you have longer appointments. You're seeing 30 to 40 or 50 patients a day, and you're feeling disengaged. You may feel a little ineffective and not surprisingly exhausted. Look, this has been a great discussion, Will, and I just want to finish up with one last question, because we are all individuals on a health journey in this modern world, and taking a step back from your role as a doctor, as a psychiatrist, just as an individual, what do you think the biggest challenge is for us as individuals on that journey in this modern world?
Wow. Well, I think I'm going to go full circle back to your comment about the Harvard study in the beginning and the issue of meaningful, deep relationships. And I think that is one of the biggest challenges, is in a world that's marked by fragmented attention and the hustle and the go, 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 and the constant barrage of the phone and the media. It's difficult to slow down and really be present and listen to the people who are right in front of us. So the more we can do that, I think the more we can we can taste the marrow of life just in the immediate moment of being really present with another person. And practicing that as much as possible, I think, is a really healthy antidote to some of the modern ills that we face.
Well, Will, on that note, I've really enjoyed being present with you here today, and thank you so much for sharing your knowledge and wisdom. We've been looking forward to this conversation for quite a few months, and I'm glad we've had it. Thank you so much for joining us today.
It's been great to be here. Thank you so much, Ron, for doing this.
Well, isn't it interesting? Isn't it empowering to know that there are so many things to consider with mental health? And this is what is so special about an integrative approach, and it's one of the reasons why championing it is such an important part of public health, empowering you as an individual to have more control. With knowledge comes power. Now, there was a lot we didn't discuss with Will, and we're going to get him back about somatic experiencing and EMDR, a rapid eye movement for dealing with trauma, desensitization, and we're using rapid eye movement, and a whole lot of other stuff. But there is a book coming out called Psychedelic Therapy that explores how psychedelic-assisted treatment is transforming mental health and offering new approaches to healing trauma and anxiety and supporting long-term resilience. Dare I say even cures. don't often use that word in mental health, but it's written by a whole range of leaders in the field and it offers a comprehensive overview. So psychedelic therapy, there will be a link to that in the show notes. And if you order a copy, you will also have access to an online summit, which is on the 6th of March. No doubt there is recordings. So the book and the recordings will be available. The summit features renowned voices in this space like Michael Pollan, who wrote a whole book on, not just the omnivore's dilemma, but also on psychedelic-assisted therapies, 𝐀𝐿 𝗪𝗏, and many other leaders. So that link will be in the show notes. I also encourage you to join the Unstress Health community. There will be live monthly Q&As, access to health coaching, access to courses. It's a great community, and we are going to be building that community in this coming year with some great resources. Also, member-only Healthy Bite podcast, which will be dealing with current issues that are occurring politically that are relevant to health and some of the things that you may not be reading about in the mainstream media. I mean, if it's anything to do with you empowering you to better health, it will hopefully be in that membership. So I hope this finds you well. Until next time, this is Dr. Ron Ehrlich. Be well.
Feeling stressed, overwhelmed? It's time to unstress your life. Join the Unstress Health community and transform stress into strength. Build mental fitness. From self-sabotage to self-mastery. And together, let's not just survive, but thrive. Expert-led courses, curated podcasts, like-minded community and support, and much more. Visit unstresshealth.com today. This podcast provides general information and discussion about medicine, health, and related subjects. The content is not intended and should not be construed as medical advice or as a substitute for care by a qualified medical practitioner. If you or any other person has a medical concern, he or she should consult with an appropriately qualified medical practitioner. Guests who speak in this podcast express their own opinions, experiences, and conclusions.